I will remind everybody that this webinar is being recorded, that it's being watched on YouTube and on Facebook at least. I have trouble keeping up with social media, but I think it's appropriate for us to begin. And thank you for joining us today as we discuss tackling the burden of RSV in older adults. And I would like to begin, particularly because the president of the World Federation of Public Health Associations at the moment is an Indigenous woman, Emma Tapato, Emma Rawson-Tapato, is a Maori woman. And for my own case, I am living on the lands of the Ngunnawal people, and I pay my respects to their elders, past and present, and also extend that to all Indigenous people worldwide. And as we go through the discussion, I think it may become clear as to why I think that is important, because it's important about looking after vulnerable people. But today we're actually talking about RSV, and generally, I think it's important for us to understand as a global population ages, health systems face increasing challenges due to the rising burden of age-related disease, of which RSV is one, and vaccination is a cornerstone to the life course approach to health. It plays a critical role in mitigating health and economic impacts. It's a seasonal virus and things will become very, very clear, but it does cause large numbers of hospitalizations, and it does cause death in older people in particular, and also in the very young. So it is something that needs to be addressed. Our therapeutic options are reasonably limited. However, new vaccines are offering some hope, and so hopefully our discussion today will allow us to elaborate a little on that. Let me now introduce the speakers that we have with us today. I'm your chairperson. I'm Michael Moore. I'm currently the chair of the World Federation of Public Health Associations International Task Force on Immunisation Policy. We have with us, and I'll go in the order of the screen, Professor Anna Banco, who's a specialist in microbiology at the Institute of Microbiology and Immunology in the medical faculty of the University of Belgrade in Serbia. Professor Mika Ramet is Professor of Experimental Immunology at the Faculty of Medicine and Health Technology at Tampere University in Finland. Dr. Christine Selvey is the Director of Communicable Diseases branch at the New South Wales Ministry of Health in Australia, and Dr. Gustavo Tato Borges is a public health medical specialist at the University of Coimbra in Portugal. Welcome to you all, and we really appreciate you being here. Let me begin by mentioning that we have a report, a new policy from the World Federation of Public Health Associations, and it is on RSV in Europe in particular. I wonder if I can begin asking the question of Professor Ramet. Does the report adequately address a focus on older people? And in responding to that, can you also just touch on the issue of evasion of innate immunity so that we understand the aspects around that?
Now, I'm also unmuted. Okay, thanks, and good morning or good afternoon to everybody. Just to add something about my introduction, that I have my professorship in experimental immunology, but my background is in pediatrics and in neonatal medicine, and in that respect, the RSV is extremely important as well. And kind of about the RSV virus, you already mentioned that it's seasonal, so that there's epidemics, and it is very contagious. So going to these pediatric patients, practically everybody get exposed by the age of 2 years, so that you really can't avoid getting an infection. And as already said, it's a really nasty disease for the newborns. Then when you get older, like from the pediatric perspective, when you are school age or teenager, then it's not that big a problem. But then it gets a problem again when you get older. And even if everybody gets it when they are young, then it doesn't mean that you would be protected throughout life. Like it's different compared to those like measles or rubella, that if you get it once, then you don't get it anymore. But RSV infection you can get multiple times. And again, it's a viral infection, and it's known that you can get protective immunity. For vaccine development, like the first trials were like 50 years ago, and those unfortunately failed. But then later on, it is known that like mothers can protect their children by giving antibodies, and it's for infants. It's known that if you give RSV or antibodies against RSV virus after birth, then you can protect those infants. So that gave a understanding that what kind of immune response might be beneficial, and that has guided these novel breakthroughs in RSV vaccine development. So you can get immune response, you get some protection by having an infection, but you can get the infection multiple times throughout your life. And as already mentioned, the older you get, the more severe they tend to be. Thanks.
So interesting to me, Mika, or others, is so even if you've had the disease or you've had the vaccination, you can later get the infection. So how regular, and we know this about flu, we know this about others, and COVID, how long does the immune reaction last generally, if it's the case of vaccination, or if it's a case of having previously had the disease? Perhaps Anna could start with that one, and I'll come back to you, Mika.
Yeah. Hello, you all, and thank you for invitation. I would also try to explain from the viral features, why is that happening? So this virus is RNA virus, it's enveloped, and many features were unknown, and they are related to development of vaccine, as Mika explained. So this virus is attaching by G protein, which is very variable, and the fusion between virus and our cells is mediated through F protein, which is less variable and very potent in neutralizing of a virus. So that's the feature that is the target for vaccine development. However, variability between G proteins, between viruses, are at a high level. So 50% of differences are in a G protein region. So today we have two groups of antigenic variability. So type A and type B, but inside those types A and B, we have today 22 RSV-A subtypes and 37 RSV-B subtypes. So that's the reason why those variabilities made the seasonability differently and made us more susceptible to get the virus again, viral infection again and again. That's the main reason. So virus is highly variable with many subtypes, differences with different how can I say, seasonal prevalency. So we can have one season with 2 or more genotypes, but probably in the next season the situation will be different. However, those antibodies are waning. So after natural infection, we have waning antibodies or titers of antibodies, and in adult population, the amount of antibodies, neutralizing antibodies, are waning in 1 year. That's significantly open our windows of vaccination implementation, because after vaccine implementation, we can see that waning immunity is not in 1 year, but in minimum 2 years. So, for example, if you get a natural infection, the waning immunity will last 1 year. But if you are vaccinated, you will be immunized minimum 2 years. So that's the major feature that vaccine will related to immunity will be delivered. Also, I have to mention that these viruses are transmitted by large nasopharyngeal droplets, not by aerosolization, and the risk of transmission varies between kids that Mika mentioned and adults. So the risk of transmission in adults is up to 30%, in kids 12%. So that means that those adults with comorbidities that are going to the hospitals and admission because of the many reasons will be at risk for nosocomial transmission. So that's the whole package of transmission that we will have as a risk for development of complications.
So Gustavo, does this mean we've got to be wary about our grandchildren?
Well, I think hello everyone. It's a pleasure to be here. Just a small clarification. I'm not linked to the University of Coimbra. That's where I graduated from med school.
Sorry.
No problem. I work at a local public health unit in the National Health Service in Portugal, right next to Portugal, called a small town called Gondomar. So I work closely with that community. From what I'm hearing, we always knew that our grandkids, our small children, can bring disease to our household and be a source of infection through our older population. But hearing what Professor Anna has just told us, I think that older people can transmit more to the household and increasingly more to kids than the other way around. And currently, I think there is a need to look at the older population more closely in order not just to protect them, but to stop them from carrying the disease into our household. We know that they are more fragile, more vulnerable to being infected due to their comorbidities, but we do need to think in a broader way to protect our older. And I think the report does state that we cannot neglect the impact of older people in our population, and we have to protect them in a global way. And that around Europe, we see a lot of variation in that kind of protection, and we do need to upscale our job, our work, to protect them all more evenly, I think.
And I wonder, I'm going to come to Lotta in a minute, who's raised her hand. I will encourage people to actually put questions in the chat. I will come to you in a moment, Lotta. But I'm wondering if the infection remains more serious in older people, and therefore the issue of the broader health systems of hospitalisation, of taking care and so forth, is also a financial burden that has to be taken into account for health systems. I wonder, Mika, if you can respond to that, and Christine, I'll ask you to also respond.
Yes, there's excellent comments from both Anna and Gustavo. Yes, the rate of hospitalization that increases towards the older, or the more likely you are, the risk of hospitalization is bigger the older you are, and it changes between epidemics. And there's, as Anna told, that there's an A and B virus and different subforms of the viruses, and they have how serious the infection are. It varies a lot, but it has been estimated that in United States that it's roughly in the range of 100,000 people are hospitalized of those who are over 60, and it's in the range of 10,000 deaths per year because of the RSV in US, and that's particularly among those who are 60 plus and who has the comorbidities. And actually, one comment still about how long the protection lasts. That now it's known that like the vaccines are new, so now it's known that at least one of the vaccine what is used that the protection lasts rather good, or actually really good compared to flu vaccines for at least 3 years, which is, I think, it's quite remarkable. And which is interesting is that the antibody titers, that those go down kind of like how they typically go down, but the protection is rather good nevertheless, which means that we don't fully understand what is the protective immunity against. But in brief, the older you are, the more comorbidities, the higher risk is that you will get severely ill because of the RSV.
And of course, comorbidities play a key role in understanding those issues as well. Anna, you had your hand up, so I'm going to go to you before I go to Christina. And I noticed that Lotta has sent me a message that her raised hand was a mistake. So Anna.
Yeah, very shortly, according to viral features and older adults, according to risk of complications and higher mortality. So there is something between the impairment of cellular immunity that is related to age and the immune response to this virus. We have that we can see that in older adults we have development of symptoms more slowly than in younger population. So very often the disease is underestimated. So in ambulatory testing, the testing is more frequent in kids than in adults. So we have the window period for developing of symptoms, complication, etc. And that we do not know in that moment that this is happening related to RSV infection. Also, older adults will shed viruses in a longer period. So again, it was the nosocomial infection and everything that is in the virtual circle between transmission and other patients. And also one important feature is that testing, as we usually use point of care testing like antigen testing, are less sensitive in older adults. That's a scientific result than in younger population.
That leads me, Christine, in particular, to a question around monitoring surveillance data systems. And you may have something else you want to respond to from the other speakers, but I'd like you to include that issue as well in your response. Are we doing it well enough? Where can we improve? And I know your reflection is particularly on New South Wales within Australia, but I think there's lessons that can be learnt and we can extrapolate to other jurisdictions.
Yes, that's right, Michael. So in response to your early question about the burden on the health system, and I was going to say something similar to Anna, in that certainly in New South Wales, if we just look at the admission rate for diagnosed RSV, it's several times higher in young children, in infants under 12 months of age, 5 or 6 times higher than in older adults. But I agree with Anna. I think that the older adults who are admitted to hospital with a respiratory infection and they may already have a pneumonia complication are less likely to get tested for RSV. And then you've just heard that in Australia we use PCRs, but also because of the length of the time since the start of the disease, they may not be detected even by PCR testing. So I agree. I think that the burden in older adults in terms of hospitalisations and therefore mortality is likely to be underestimated. And we certainly know that we get excess deaths in the winter season. That's also complicating the increased burden on the health system because many of the respiratory viruses are all circulating at the same time in the cooler months. So it does place, in combination, particularly with influenza and these days COVID, although it's still not seasonal, significant burden on health systems during those winter months. But yeah, I think the actual contribution to RSV, particularly in adults, is underestimated.
Gustavo, you've listened to this and I've been listening. What are the main next areas of research that we should be looking? Where should we be exploring at the moment? Because research is your basic focus, isn't it?
Well, so not the main focus.
Okay.
As I said, I work in the local public health unit with the community, so my focus is to interact and to work with everyone citizens and main community leaders in order to improve health in a broader sense. But we do
I think we would all love to be doing that. I think that's actually the agenda we all have in a way. So, and you've put it beautifully. So thank you.
I thank you. But it is a very interesting work, but it's a very hard work because we all tend to have different objectives in our life. So sometimes being able to put health in all policies as we all like to tends to be a bit challenging. But it is a very interesting work, and feel free to come and visit us, and I'll guide you through what we do. But just to complete what Dr. Christine has said, there is a lack of data available for older adults. I have to say Portugal has done something a bit different in the last 2 flu seasons, I think, because with the COVID pandemic, we have increased our laboratory capacity to test for multiple viruses at the same time. And so now we tend to test more broadly for all infections. And we do know that this current flu season, RSV infection corresponds for 12.5% of all respiratory infections in older adults, give or take something. It's the third main cause of infection besides flu. So it does have a bit of knowledge. Now we do have a bit of knowledge now. It's still I think it's still a major source of burden for our older adults. And it is, we also know from people that are committed to hospital with serious infection that RSV is the second main cause of being committed. I think that we need to still learn a bit more about the way RSV virus communicates in the community. So we have to test more, get more people to be involved in this investigation, and maybe see how it impacts in terms of the money that we spend in hospitalizations, treating these people, and understanding the advantages of giving vaccination for older adults. In Portugal, currently, we do not have any kind of recommendation, official recommendation, or we don't help to pay for the vaccination. So anyone older adult can be vaccinated. There are 2 vaccines available in Portugal, but they have to be bought with a medical prescription and paid for entirely by our older adults. So I think there's an economic study that has to be done in order to see the main value that we can get from vaccinating broadly our older adults. I think that's one way of going.
On that point, I'll go to each of you, but I'm going to start with Christine, because Australia has actually implemented some policies on this at this level, haven't they?
Yeah, so we do have in every state and territory an RSV prevention program, but only for infants. And that's a combination maternal vaccination and neonatal nirsevimab, so monoclonal antibody program. For older adults, we have recommendations for vaccination. RSV vaccine and also 2 available in Australia for all adults aged 75 years and over, and those aged 60 years and over with a medical risk factor, or one of our First Nations peoples who are aged 60 years and over, also recommended to have a vaccine. But similarly, it's not funded. It's relatively expensive, costs about 300 Australian dollars. Both the vaccines are similar in price. So really sort of not affordable for most people, particularly at the moment. We're experiencing a cost of living crisis like many other countries in the world. So until there is a submission to our Pharmaceutical Benefits Advisory Committee with some data to show cost effectiveness, then it won't be funded. I think there's also a lack of data about the need for boosters. So when those antibodies wane after 2 years, as Anna explained, should there be a recommendation for a booster? If a booster is required every 2 years for older adults, then clearly that's a fairly big undertaking to do it universally. So I think still some questions to be answered before we'd have a funded vaccine program.
Yeah, particularly in the context that Gustavo raised about financial parameters, and in the end, decisions are made within the amount of money that you have available. Mika, you have your hand there.
Yes, thanks, Gustavo, and a good comment. Yeah, it's and also for Christine, it's really kind of the key question now that when the booster dose should be given, and it's really totally open question at the moment. Still about those, what I find interesting, that it's really well known that in trials, the vaccine efficacy is like 80% plus, and then for the next year is perhaps a little bit 80%. Then it's known that even if you get infected, then the infection is less severe compared to those who have not got the vaccine. So even if you get the disease, you are still on a better side if you have been vaccinated. What I'm particularly interested in knowing is that once the vaccines are included in the national vaccination programs and they are largely used, that what will be the real world effect of the vaccines. It's known that there's seasonality in mortality as well. During the winter or the colder months, you have excess amounts of mortality all years, and not all are kind of counted for influenza or RSV infection directly, but it will be interesting to see if there's an effect also for like cardiovascular events, that there are less cardiovascular diseases for those who get the vaccine. So there's still many exciting things to be seen, and kind of that my expectation is that the health benefit is even broader in the real world than just the reduction of the RSV cases. Thanks.
Yeah, I often wonder about comorbidities and where people have had RSV, but actually the death or the severe illness is associated with one of the comorbidities rather than with the flu virus or or COVID or RSV. Anna, I know you're busting at the seams there.
Yes, very interesting about Mika explained us. There are some modeling studies. They try to adjust something that we underestimated. So according to those data, according to comorbidities and everything they included in those modeling studies, they assumed that we underestimated 2.2 times RSV hospitalization and the impact of the burden of health system. So, for example, according to that, the risk of and the rates of RSV hospitalization are 200, around 250 in 100,000 people. So this is much more that we know. and also about cardiovascular events. So up to 63% of adults admitted hospital with RSV positivity have cardiovascular diseases. So we know everything about pulmonary diseases, chronic lung diseases that are in a basis of these patients, but also cardiovascular are very important. Also, those people, when we are talking about adults and elderly people, they're more prominent to have co-infections. So if we compare adults and children, so we have co-infections up to 22% of viral co-infections, not only bacterial co-infections, and also up to 23 bacterial infections. Why is that matter to us? Because on one hand, you have slow progression of RSV disease, but RSV as a virus is not cytopathic. So it only goes to superficial cells. But after damages of that superficial cells, the complication rises in superinfections. So something that is underestimation is also related to viral infection and pathogenesis. So that's very important and very interesting. So if we include, for example, vaccination, probably we will have results on many comorbidities that we saw in these people.
Thanks, Anna. We have a comment question from Chloe Rimacon, who says, so should we be looking at prevention measures? Should we be looking at asking people to wear masks at the peak season so that we can be preventing the spread of the disease? What role does it play? Can I start with you, Gustavo? Go to Christine on this one.
Well, I think wearing masks, respiratory masks, are always a way to protect ourselves from getting infected, respiratory infections. And older people or more vulnerable populations have greater advantages of using it. We can always recommend it, especially when people tend to have the need to go to an emergency room to be because they are ill or they had an accident, and there are other ill people around that can transmit any kind of viral infection, respiratory viral infection. And so I think it is always a good recommendation for when you are ill or you're going to a place where there's a lot of people and you're a vulnerable citizen, to recommend them to wear a mask. I don't think that we have any kind of value nowadays, after COVID pandemic specifically, to have a mandatory regulation for using masks across the nation. I think European citizens mainly, but I think over the entire world, are a bit wary and tired of being forced to wear a mask. And we have to tell them of all the advantages. We have to influence them to wanting to wear one. So there are advantages. I don't think being mandatory will be a very good policy.
It's a prevention paradox again, isn't it? Whenever we're successful in what we're doing, then people get very relaxed and don't worry about it anymore. So it's one of the things we live with in public health. Christine.
Yeah, I agree. I mean, I think with mask wearing, it's tricky. With COVID in our residential aged care facilities, we do ask them to wear masks. In fact, we ask them to wear masks. So that's all the workers in the facility. If any of either respiratory, RSV, influenza or COVID are circulating at moderate or high levels. And so in the last 4 or 5 years, we've only had a very short period earlier this year where we had all of those 3 viruses circulating at a low level. And I think it was really tough on some, aged care facility patients, where they said, well, they hadn't seen anyone smile for 2 years, any of their workers, because they couldn't get the facial expression. So I think we sort of have to remember that faces and connection are actually really important, and masks can interfere. Having said that, I think if we could have a population who was happy We do say stay home if you're sick. That's also not always realistic. But if you are, someone is unwell with a respiratory infection, at least they could wear a mask when they go out and when they're close to any other people. I think that would be a really useful thing. And we do encourage people not to go and visit their grandparents in an aged care facility, if they are unwell. If they've got a RAT test, then, do that before they go in, especially if they're being unwell. And I guess similarly what we've just heard today about transmission of RSV from older adults to children, we certainly don't want people with respiratory infections being around tiny little babies, so neonates and really, children, certainly in infants and probably up to 2 years, when we do know that they can get, severe infections from RSV and also influenza. So I think there are some things we can do around, when people are sick, wearing masks, and also then avoiding others when they're unwell as well.
Yeah, thanks. Any comment from Anna or Mika? Mika?
Yes, I don't disagree with Gustavo or Christine, that I guess that not soon people are wanting to have masks routinely used anymore. But on other words, during like this restrictive measures, what they used, including masks during the COVID pandemic, that stopped RSV circulation. So that is an effective way to protect from RSV for sure. And the challenge is that I think that you are, if not the most, but at least you are contagious even before you start to feel sick, which is the kind of the problem wearing the masks. And I kind of just encourage people that if you, for any reason that you don't want to get sick, then you can wear mask. Like, for example, that you have an important event in a week or in 2 weeks, then certainly you can wear masks and protect yourself from getting sick from COVID or influenza or for RSV. Thanks.
Even though the people around you won't see that beautiful smile. Anna, did you want to add?
I guess you can see it from the eyes.
Yeah.
Yeah.
You can see
fake
smiling
more
eyes.
with your mouth, and then with your eyes, then you then really can see if you are smiling.
It's true, yes. And I particularly noticed that at times when I was in Saudi Arabia. Anna.
I just could add that a little bit raising awareness in, according to intra-hospital transmission, I think that if we manage to do this, to decrease transmission intra-hospitally, we will do some important work. So controlling visitors, controlling doctors, nurses, and that they should wear masks or be protected at least against influenza. And after that, the rest of viruses would be great achievement. I'm talking about maybe not Australia, but according to something that I see here.
I think Christine may correct me, but I think same story in Australia, Anna, of course. But you do raise an important question for me about Europe, and to what extent is it important to ensure that the policies around RSV and probably other respiratory viruses are harmonized, the policies are harmonized. In Australia, we have to actually harmonize between our jurisdictions, between the states and the territories. I think it's more challenging in Europe. Is it important? Let's start with you, Anna.
For Gustavo or me? Gustavo?
Anna.
Yes, it's very important because in Europe is very different situation from monitoring, testing to vaccination policies, etc. So, for example, there are countries like Serbia that we have not regulated monitoring programs of RSV. So this is the beginning for everything, because without the data, as Mika told us, without data, we cannot improve or develop any policies. So we have differences in screening, monitoring, etc. that I explained, but also, as you can see, for regulations and everything that is for propositions for RSV vaccination in countries that they have RSV vaccination, you have differences. So in USA or Australia, you have limitations up to 75 years with comorbidities and risk, and 75 and plus for in general vaccination for RSV. But in Europe, as I can see, there are many differences. For example, 50 years old and above, 65 years and above, 75 years and above. So that harmonization is important. Why? Because that's something that patients now can read and can see. So for example, if you have different dosage, or if you have different policies, different limitations, they're all, I can say that they're not only confused, but they ask, why is that? Is it any safety concerns? Is it any financial concerns, etc.? So we are rising and developing some kind of questions that are not maybe necessary if we are all in a unique way, similar at least.
It's so important at this stage where we see so many people questioning vaccination. And so when you have your national immunisation NITAGs and national immunisation advisory groups, technical advisory groups, who are all coming up with different solutions, then you have a significant problem just in terms of questioning. And apart from the fact that we ought to really get at least pretty much a harmonised view. Gustavo, what do you think? And then to Mika.
Well, I think it is very important to have some kind of similar policies, harmonizing everything from testing to surveillance, defining what is an infection through VSR, the vaccination policies, etc. Due to all these variabilities we have spoken about, and also others, housing quality varies around Europe, the burden of disease varies around Europe, and we have now very different ways of looking at politics, and we are changing the way the governments in Europe are shifting towards some kind of policies that are against these broader immunizations, these broader interventions, protecting everyone, being more independent for whatever citizen wants. So turning, mainly, I'll say this broadly, turning right in all these politics ways, and it may be extreme right in some countries. And all these variables, and we've seen it through COVID, make the citizens' perception makes it biased. So they don't tend to have access to all the information, to all the prevention policies, to all the opportunities for them to protect themselves, because everything turns political. Everything turns to what my leader tells me to, and I follow what he says all around, maybe sometimes without questioning. So if we can work together in order to have at least some kind of common sense, some kind of understanding for all these questions, maybe we can sometimes protect more our more vulnerable population, being kids or being older people, and limit what negative effects can come from these different visions around Europe mainly, but around the world.
No, around the world. Gustavo, very regularly, and Christine won't be surprised by this. When I give lectures in public health, first or second slide will say, public health is political. And of course, I was a politician myself. I was a health minister. So I probably have a particular perspective there, but I think you elaborated on it beautifully.
I think you're very correct, Michael, because everything turns around. Everything can be political, and public health touches a lot of fragile subjects and a lot of sensitive subjects that politics has to take a point and a stand and a decision. So we have to be there, and we don't need to be in this party or that party, or you can be as broad as you want, but the importance is to make presence and bring science and bring public health to the discussion in order to prioritize where you have to be. But I think, yeah, politics is a part of public health, no doubt.
Mika. Mika, you had your hand up, but you're on mute at the moment.
Okay, now, yes. So I a little bit disagree with you, or I see it from different perspective, that my question, whether it's political or whether it's question of money, and is that the same thing? And what I mean is that I agree that the guidelines are important and recommendation and the data. And kind of my point is that it's important to know that what is the number needed to vaccinate, that you get something, because then it becomes question of money, because at least in my country, in Finland, we can't do everything.
Yes.
That we need to choose what is the intervention or treatment or prophylaxis or screening what we are going to do, so that whether we get more health giving vaccine to someone who is healthy, 58-year-old, or whether we, for example, do breast cancer screening or prostate cancer screening. So that way it becomes a question of money, and I presume it's part of the being about politics.
Indeed.
And that's why it's really important to get the data that we can say that if we vaccinate this subgroup, it costs this amount of money and we get this amount of help. Thank you.
Mika, just to write an insight, I think as a health minister, 2 or 3 times a week, I said no to really good ideas because I didn't have the money, and because there's something else was a higher priority. And that's not easy, but that's politics. That's the decision-making, setting priorities. So I think that's a really important insight. Anna.
Yes. To add and to make a summary of this, my concern about this is to set reasonable policies. So just reasonable, not to vaccinate over 60. No, we have no vaccines, we have no money for that, etc. And to set realistic goals. So that's something that Mika and Gustavo told us. So if you set realistic goals according to politics, finances, etc., you will make realistic policies. So that's something that could confuse some populations. Why I'm vaccinated at 60 and in another country at 75, I don't know. So yeah. If we make the balance between everything that we have and reasonable policies and realistic goals, that's something that is important. Sometimes we set non-realistic goals, and it turns around that vaccines are not effective or that they're not good or something like that. So that's very important from my side.
Yeah. Christine, any comments on that one?
Oh, I agree. I mean, the politicians basically setting policy is really about where's the money going to get spent. And that, it's government money, and governments decide where it's going to get spent. And I think right at this very moment, politically, in many countries in the world, there are very big questions being asked about where countries are going to spend their money, even bigger than usual. So, I think it's quite pertinent, because at the moment in Australia today is budget night, which is the Commonwealth Government has handed down its budget, annual budget, and it's a pre-election budget. But we're all waiting to see what's in the budget, I guess. And that's because if there's a new vaccination program, often that will be announced on budget night by the government, saying we're going to spend X million dollars on funding RSV for pregnant women, a vaccine for pregnant women, for example. But we're not expecting anything big yet in vaccination-wise this budget.
And Christine, we really appreciate you being here while the budget is being brought down instead of watching it. And for me, as a past politician, I can't help. I'm very fond of looking at that. So it is important, though, to me that our NITAGs, our National Immunisation Technical Advisory Groups, get the policies presented to government in the most effective way. How can we get our best bang for buck? And that becomes a really, really important question, and that helps us get past whether the politics are a bit to the left or a bit to the right, and I think that becomes pretty fundamental. I have a last question I really wanted to explore about vaccination strategies in general and RSV in particular. So when we develop our strategies, do we just focus on the most vulnerable groups, or do we take a really big picture as we did with polio? And you can see my wrong side, end polio badge there. We're very close. It's been a huge international effort. Similar with measles, although we can see that breaking out at the moment. What are the best vaccination strategies, first for RSV, but then more broadly, if I can ask you that question? Gustavo, would you like to begin to wrestle with that one?
Wrestle is the right word.
Yes.
It is. It is very well. If we think of it in a perfect way, of course, we would think of this vaccination in a broader sense, looking at all the population, who could benefit more and less, and how we could project the vaccination calendar around a decade in order to protect all of the people that we need, all the citizens in our country. But I think since we know that there are money restrictions, that not everyone will want to be vaccinated, there are problems in logistics and traveling with our vaccines, etc. I think the first step in every country is to know what is the reality of that infection, of that disease in their country, who gets it more, who dies more from it, who has the worst consequences, and work from that information in order to protect the ones that have the most benefit. And after that's consolidated, we can then broaden our spectrum of intervention. I think the most effective way is always to look where we can have the most impact with the least amount of money, and in the fastest way. So maybe for me, from what I have no experience in our national advisory board for vaccination, but I think that is the first step is always who needs it more, who benefits from it more, and how can we prevent it. I think that's the first step.
To add something on Gustavo, everything I am on the same side. But something that we can add here is something that we call co-administration. So if we are related to seasonability of RSV, together with influenza and COVID, not exactly the same, but similar, we can implement. So if we add possibilities for implementation of this vaccine, the positive side is that we could give those vaccines together. So the RSV vaccines are protein-based or RNA vaccine-based, so they could be co-administrated with those. So if we look at the population of the highest risk of complications of respiratory infections, as we mentioned, 75 and more at least. So we could this population use and for a target population for co-administration. So the good thing is that we have those patients in the ambulance, static care, since everything that are aware of vaccination and prevention, and we can use this. This is something that is tricky in just one setup. Those vaccines are new. So if we co-administrate all 3 vaccines as it is intention, it's reasonable, it is less likely to differentiate adverse effects. That's something that just one thing that we have to be aware.
Yeah. And adverse effects in vaccines, although they're very rare, it's
Yeah.
one of the most important things that we acknowledge. They do happen, and some people suffer for the benefit of millions of others. And it is something that I think it's the subject for a different webinar, but it is an important thing for us to acknowledge. Mika. Sorry, Anna, you finished then.
No. Just something that's very interesting. For example, adverse effects that are usual, like redness, swelling, and pain. Something that's very interesting, that are less frequent in adults for RSV than in young population. So that's something that's very interesting. Yes, only one adverse event, like fatigue, is much common in older population, but it's not nothing that's alarming. And also something that is monitoring is Guillain-Barré syndrome, but it's not something that is alarming at this point, just to be monitored. So
yeah,
safety is.
And I was speaking about alarming ones, not about the redness in your arm and feeling
No, it's
ill.
not. It's usual, yeah. But let's
shows the vaccine's working. Yes.
Yeah.
Mika.
Yes, extremely important issue. And to my understanding is that there was some doubt about atrial fibrillation, like this arrhythmia, about the vaccines, but it seems to be based on the real world evidence that that's not really a case after all. So it's really important to follow this harmful effects as well, even after licensing using the real world evidence. Yes, but my answer to this original question, that can we eradicate RSV and should we vaccinate everybody? The current vaccines that they are giving this 80+% protection, so it implies that we can't eradicate the RSV. So that would indicate that points towards giving the vaccine for those who benefit the most and try to prevent the severe cases as effectively as possible. Thanks.
It's a really important insight. So thank you very much. Christine, last word before we go to acknowledgements.
Yeah, I mean, I think this whole question about how you prioritise things in public health or in health generally, but also then amongst vaccines and given limited budgets, there's a whole new set of vaccines coming in the pipeline, I understand, and so how governments are going to try and prioritise what they do fund, I think are really difficult questions that certainly I don't have any answers for, but really, as others have said, looking at the characteristics of the illness and the burden of disease and who gets it and how sick they get, and then what the vaccine can actually do. One of the greatest achievements, of course, is the eradication of smallpox. And we got so close with polio with vaccines. Infections that aren't zoonoses and that can be prevented in the long term completely by vaccination.
Yeah. Look, thank you, Maria. Can we have our final slide up, please? I'd like to acknowledge, first of all, our speakers. Thank you so much for joining us, Professor Anna Banco, Dr. Gustavo Tadeu-Borges, Dr. Mika Ramet, and Dr. Christine Selby. This webinar would not have been possible without the University of Geneva, the World Federation of Public Health Associations, and with the support of GSK. So we really appreciate that, and we appreciate your efforts. I think this evening we've had some really brilliant insights into vaccination broadly, but particularly into RSV and the challenges that are there ahead of us, and what we can do to begin to ensure that things are getting better. The health of our population is getting better, and particularly that focus on the very young and elderly vulnerable populations. So thank you, everybody. And with that, I will now close the meeting. So thank you and good night, good day, good morning.
Thank you.
Thank you, Michael.